Thanks so much for joining on your Friday during lunch, I assume, and during a very busy day. My name is Brittany Bear. I'm the marketing director at Luminopia, and we're also joined by Dr. Derek Sprunger, who will be leading the discussion today. Just want to cover off on a few reminders. This is a program hosted by Luminopia. Dr. Sprunger will be sharing a lot of his own clinical experience with our treatment, so his opinions are his own. And he just has a few slides that we'll run through. And then the majority of the time will be spent hopefully answering any questions that you have at the end of the presentation. So we have just 30 minutes with you all. So Dr. Sprunger will review what Luminopia is, highlight some key data from our phase 3 trial, and then he'll also share his approach to using Luminopia at Indiana University, along with sharing a real-world patient case of his, and then we'll open it up to questions. So we are very honored to have Dr. Sprunger join us and take the time today to share his experience with Luminopia. And if you don't already know him, he is the professor of clinical ophthalmology at Indiana University School of Medicine. He's the former president of APOS, a past president of IPOSC, and the Indiana Academy of Ophthalmology. Dr. Sprunger has also served for the American Academy of Ophthalmology in various roles, is a Parks Bronze Medal winner, and has been inducted into the Pediatric Ophthalmology Hall of Fame. So thanks again, Dr. Sprunger, and I will turn it over to you.
Well, thank you, Brittany, and also thank you to everybody attending. Just before we get started, I think some of you know quite a bit about this Luminopia, and some probably not much at all. I'm going to try to hit the middle between those two groups, and some of you may be, well, I knew all that already, and that's okay. And then some are like, well, he's talking over my head. I'm not quite sure what you're talking about. I'm going to try to hit that middle, and if in the question answer session you have something more detailed you want to talk about, that's fine. Or if it's more basic, that's fine too. Happy to talk about any questions you have, and look forward to that part as well. But to get started, first of all, if there was a perfect treatment that was already in existence for amblyopia, there would probably not be a Luminopia. But as you all know, there are many hiccups in treating amblyopia, and parents and children are often frustrated with the current treatments, as evidenced by this young lady with the patch on her eye, and she's not very happy. As you know, monocular treatments have been the standard of care up until now, basically. And oftentimes children are asked to patch 2 to 6 hours or more a day, which, as you know, can be very challenging. And what parents report to you is not oftentimes what's really happening. It's been estimated in a clinical trial setting that there's about a 44% compliance rate with patching. So there's something missing there, and it can be improved upon. Thought is that Luminopia can probably help with that. And the other factor is that even with patching compliance being good, there still can be residual deficit, and that can be improved upon. So we'll go to the next slide and mention that this Luminopia gives kids a new choice, and they watch TV, basically watch TV for their treatment. So what is Luminopia? It's actually the software. It's not the hardware. It's the software, and it takes TV shows and modifies what's projected to the child through a therapeutic visual stimulus. Currently, there are 1,100 hours of curated content from 75 TV shows. When I was doing treatment early on, one of the minor issues that I was confronted with is that there wasn't enough variety in the content, and that's been dealt with regularly by Luminopia by adding TV shows, adding things that are going to meet the needs of more and more patients. They're constantly updating what content is available. The device is an immersive, distraction-free environment, and the headset is light because one of the concerns that some people had is it's going to cause neck problems in kids. The device weighs around a pound, so it's very user friendly. And it's the treatment is very simple and kid friendly, being 1 hour a day for 6 days a week. We can go to the next slide. This is actually how Luminopia work, and it operates with a different mechanism than has been utilized in the past. It's a dual acting binocular mechanism, which encourages both eyes to work together to improve vision. The two different mechanisms are, number one, contrast reduction in the stronger eye. It reduces the contrast to 15% of full contrast. And at the same time, there's dichoptic masking. What this means is the masks are seen in both eyes. And you can see in the picture on the left, the stronger eye with more contrast reduction. And the pattern, you can see certain areas are have more contrast reduction in both eyes. The area that has this contrast reduction varies. Every 30 seconds, it shifts to a different area. There's six different patterns that will be projected into the eyes. This encourages the eye's full field of vision and keeps the brain stimulated throughout the full hour while they're observing. So this is basically what the headset looks like. One of the things, just bring it up now while we're looking at this, some people are concerned that this is a lot of near viewing for a child. Is it going to induce myopia or cause eye strain or other things like that? The actual image is broadcast such that it simulates distance vision. So there's thought that there's not going to be issues with close-up, using a lot of close-up vision. So it's projected at distance. Okay, we'll go to the next. And then we're going to briefly go over the clinical trials. There were 2 initial trials, and then to get FDA approval, the FDA was consulted for a phase 3 multi-site study for a broad patient population. And basically, the primary endpoint in this study was the change in vision in the amblyopic eye with best corrected vision at baseline and at 12 weeks, with several checks in between that baseline and 12 weeks. And the key eligibility criteria basically mimic a lot of previous amblyopia treatment studies, particularly the PDIG studies. And for this study, the age was 4 to 8 years and unilateral amblyopia from anisometropia, and allowed to have up to 5 prism diopters of strabismus by a simultaneous prism cover test. The amblyopic eye range was from 20/40 to 20/200 with a 3-line difference between the good and poor eye, poor seeing eye. And then also patients that had had more than 1 year of prior treatment were eliminated from the study. And again, this was to keep it consistent with previous amblyopia studies. And also the thought that if the patient's been treated for more than a year and not responded, you may have a separate patient group there. So those patients were left out of the study. We'll go to the next slide and see the results of this phase 3 study. What it reveals is on the vertical axis is the lines of improvement of visual acuity at 4, 8, and 12 weeks, which again was the primary endpoint. And in the blue being the number of lines improvement using Luminopia, and in gray, the glasses alone treatment. And you can see statistically significant improvement in vision in the Luminopia group compared to the glasses alone group. There were no serious side effects. There were several patients who had headaches, and whenever the use of the Luminopia was stopped, the headaches went away. There was one other patient who had an adverse event, which was the patient already had night terrors, and they thought they maybe had a few more night terrors when they were utilizing the treatment, but that went away at the end of treatment. So this is what gave FDA approval for use of Luminopia. We'll go to the next slide. So we're going to review a patient of mine, just to kind of give you a typical scenario in my experience. We pulled one out, and this was a 7-year-old girl who had moderate amblyopia. She had refractive amblyopia in the right eye, and at 3 years of age, she was diagnosed, had 2100 vision, 20/30 in the sound eye, wore glasses, and did some patching for 3 years. So she would not have qualified for this the phase 3 trial because of that 3 years of patching. So she was 20/30 when she saw me at 7 years of age, and they said they're done patching. They're happy wearing the glasses, but they're done patching. Are there any alternatives? So Luminopia was discussed with the family, and they decided to proceed with the use of the Luminopia. Here you see on this graph, basically the vertical blue lines are the number of minutes each day that the device was used. The device has the ability to detect if it's being used, and it's basically based on micro movements. If the child takes the headset off and it sits still, it records it as not being used. If the child falls asleep and their head's not moving, no even any micro movements, it reads it, it's detected as not being utilized. So you can see on there the utilization of this. And then we see the baseline where she's 20/70 in amblyopic eye, 20/30 in the sound eye. 5 months later, 20/50, 20/25. A couple months after that, you can see after that 20/50, there was a gap in the utilization of the device. They came back at 8 months, and the vision was 20/60. And we asked them to pick up the use and use it more consistently. Came back at 11 months, and we now have 20/30 vision in both eyes. And we tapered off, and the visual acuity remained good and the same. So there was a 96% adherence. So we know it was actually being used, and that kind of, I think, helps us to know if we're not seeing a response, is it possibly due to not utilizing the device, and we can determine that. So this is a pretty typical patient for me, having used Luminopia. So the next slide, we'll go over and discuss kind of how I utilized Luminopia early when it first came out, and where I am now. At first, it was basically treatment prescribed when everything else failed. If somebody had done patching and had failed, either not responding or compliance issues, or if a patient didn't want to use the atropine anymore. So basically that was what I used it for. And over time, I've gradually changed. And at this point, a lot of times I try to have a discussion. First of all, kind of knowing the parents and kind of perceiving what their thoughts are, what if they have any preconceived notions about treatment. And at this point, with appropriate parents, I'll introduce all 3 treatments and discuss each one basically, and have their involvement. And and the other thing, so that's the choice of patients, my patient selection. And then also I've expanded a little bit to older kids, because the trials were 4 to less than 8 years of age. And I've expanded it beyond 8 years of age, and seen some improvement. And I have not limited it to 2200. I've actually placed some kids who have more severe amblyopia. But the indications from the FDA were mentioned in that phase 3 trial, but I've expanded it beyond that, just based on family interaction and kind of perceiving what the family wants to do. So I'm constantly evolving. And some of the determining on these kids who fall outside of that 4 to 8 year range and the 40 to 2200. I think a lot of that's going to be sorted out with the pupil registry, which is designed to collect real world data from patients of all ages, vision levels, et cetera, at different sites around the country. And as we kind of expand that, as that database is expanded, we're going to know even more accurately who we think can respond and tailor a treatment to each patient individually. So with that, that's my part of the talk. And I think, Brittany, I'm going to turn it back over to you.
Yes, thanks, Dr. Sprunger. So we'd love to hear any questions that anyone has. I know there's already one in the chat from Dr. Bergo asking about use in bilateral amblyopia patients and strabismic patients with a greater than 5 prism diopters.
Great question, Dr. Barrago. There's no results. We don't have results on bilateral amblyopia. I know it's being tried, and if there are any comments from the Luminopia folks, if they want to comment on it, but it's being tried. We don't know results yet. Regarding the strabismus greater than 5 prism diopters, I actually have utilized it in patients more than 5 prism diopters with what I consider good results. And again, I think we'll have better data on that as more comes out. But I'm trying it because I get to the point where if a patient's not going to patch, they're not going to use atropine, et cetera. I offer it to the parents and I tell them we don't know for sure whether it works. We know it's not going to make anything worse, and it may work. I think, if you have a 10 to 12 diopter strabismus, certainly try it for that. You get up 20, 30 diopters, maybe it's a little bit outside the range of a realistic possibility that'll help, but we don't know at this point. But certainly 5 is just a number that was utilized for the study, and I'm using it for more in select patients.
Thank you. Just trying to see if there's any other questions. Can you maybe share a little bit more, Dr. Sprunger, about how you explain Luminopia to parents in an easy to understand way, and what do you make sure you call out in those initial conversations?
Yeah, I mean, I don't call it experimental by any means anymore with the data that we do have. But I just give it as an option and explain to each family what I perceive, what they want to know about it. And I've had some people get very detailed in results of studies and whatnot, and others are just like, oh, we're so sick of patching, we can't wait to try this. So it's quite varied in how I approach it. Another thing I did want to mention, whenever I started using it, I talked to the office staff and they said, if this is going to cause you to spend 10 more minutes with every patient, we can't do it. And also if it's going to cause a lot of disruption for the office personnel, particularly we have a technician who we identified to be our point person for this treatment. It takes very little time and it does not stress the office flow to utilize the Luminopia. Basically, and some of you may know this and some may not, basically when we identify a patient, the patient wants to do it, there's a fact sheet which you fill out. It's sent directly to the pharmacy and they take it from there, and all we do is schedule a recheck appointment. So it's made extremely easy, and I give the Luminopia folks great credit because they listened, and we actually asked for a handout, which is very concise, that we can give to a patient. What do they want to look at while they're in the waiting room if they're dilating? And then second of all, to take home and look at, and it's a great material, and the company's made it very easy to use, which for us was critical because we just don't have an extra time to spend on that.
Awesome. Okay, another question. Maybe this is better answered by someone at Luminopia about the specific headset used. Will Luminopia be shipped on newer hardware in the future? There are some headsets with different technology. I know Endry's on the line too from our clinical operations team or clinical development team, but right now the Pico headset is what's currently being used for all patients. I don't know, Endry, if you want to add more.
I think that's right. It's a headset that we've had good feedback from patients, and they seem to like it. We'll be continuing to use it for the near future. Um, as we go into 25, we may introduce a new headset, and if we do, it's going to be even better because as technology goes, it just improves over time. As you know, these are off-the-shelf headsets, so it's not headsets that we're manufacturing at Luminopia. But as new headsets do come on the market, we do evaluate them.
Thank you.
Andrew, he also asked the headsets with Fresnel lenses and lower resolution can have more smeared images or screen door effect. Are you familiar with that? And would you have an answer to that?
Yeah, essentially, all the headsets, how we evaluate them is based on the headset that was used in clinical trials, which at this point was about 6 years ago. And the resolution and the image clarity are benchmarked off of that, meaning they just have to be as good as, if not better. And the FDA actually evaluates this with us as well. So that was an old headset that's no longer on the market that we did our studies with. And the Pico, which all of our patients are on now, is already an upgrade from what was used then. So from an image clarity perspective, it's only going to get better. And there's a bunch of other variables beyond even just the lens that go into, hey, what makes a clear image in a VR headset?
Thank you, Andrea. And then Kristen says, will more shows be added for more appropriate for older children population? I have had feedback that most shows are geared toward younger children. Absolutely, and I've had that situation, discussed it with Lumino. I called and mentioned that, and they're actively working on expanding the content. They just increased it, this past December, but it's constantly evolving. And they may need to get up to stuff for teenagers. That's a possibility. And I don't think teenagers are going to watch Bluey or a cartoon like that. Absolutely. So yeah, they're working on that. And if there's any other comments from you folks at Luminopia.
No, I think that's spot on. I know our engineering team's #1 priority is content library. So hopefully can share more updates soon. And then we have another question about wanting to know more about what the family does when they get the headset. Is there any alterations the parent need to do to make it work? And is there any calibration? No, the headset comes ready to use right out of the box. All they have to do is connect to the Wi-Fi and enter in the access code that is sent by the pharmacy. And then everything's preloaded and there's no calibration step required. I don't know if anyone wants to add anything else.
Yeah, I can add maybe a bit. So it's like Brittany said, there is no calibration. And we do have a support call that patients call when they have technical difficulties and other non-medical questions. And I don't believe we've gotten one question about how do I put the headset on and how do I go, so to speak. There might be questions about Wi-Fi every now and then that we answer, but the headset is very user-friendly. We have a little, three pager pamphlet that shows the parents how to put it on, how to get going on treatment, and patients don't seem to have any issues with that, caregivers or patients.
Just as an aside, I've not had one family have an issue either or state an issue with, how do we get this thing running? So whatever instructions they're getting have been sufficient. So I've not seen that as a problem at this point. Someone asked about the PD range. Is that 52 millimeters? Is that
Yep. Mm-hmm.
Yeah. So down to 52 millimeters.
And the headset that we do ship out doesn't have an adjustable IPD. The range of the IPD is tested for and is big enough to fit kids 52 millimeters or larger.
Another question about content only in English, and if there are any other languages available. It's the content on the headset is English only at this time, but I'm happy to hear any feedback on what languages would be helpful for your patient population so we can add it to the list of ideas.
I do want to add that our labeling, so the user manual, as well as the welcome guide, do also come in Spanish. So while the content, the shows that are on there, which is the content, is in English, the instructions for use are both English and Spanish.
Yeah, good point. These are all really good questions. All right.
I can also mention if anybody has any questions for me offline, don't hesitate to contact me.